So it may actually delay, downstream care by doing that. So so that's a good one for online medical control. Is why we left that there, just so people are aware. So plus, I really feel like we should be using online medical control more. It's a really good resource. I do the same thing all the time when I talk to people about things that are complex. So it's not weakness doing that. It actually probably shows that you have a better understanding of some of the problems you may run into down the line. So the dose is code dose 300, and then BPAC with a pulse is 150. We're probably not going to be starting the drip, to be honest, but it is are you guys starting the drip very often?
Yeah, that's the other line. That's with the BPAC and pulse. I mean, pulse arrest doesn't exist anymore, at least from the ACOS.
Yeah. Let's see, aspirin, I don't think any changes. Just to bring people up to, so the recommended dose is 324 milligrams. If someone says they took 81 just before you get there, you could bring them up with 3 additional ones to 324. That's a good dose. There's actually good evidence that 160 milligrams is as efficacious, so I wouldn't get all bent out of shape about this stuff, but right now we're recommending a total dose of 324 milligrams. Let's see. Atropine. Let's see. There is some concern that with AFib and flutter it may speed up tachydysrhythmias, and that's with people who have an accessory pathway. So you may block conduction through the normal pathway, which could accelerate it through like an accessory pathway. That's pretty uncommon, and most of the time, to be honest, still pretty safe, but be aware if someone says they have a history of WPW, they could do that. We're not using it in the codes as much anymore, ever. So remember the organophosphate dosing for this is much, much higher. You will not carry enough on your rig for organophosphate poisoning. So that's like a good thing to notify the hospital if you have organophosphate poisoning, because that may be requiring activating the Kremkau to get enough atropine to do that. So,
how concerned should we be with the bradycardia? It's just always a question with MI.
I think it's very low risk. And in fact, some people with right-sided ischemia who are in third-degree block are actually responsive to atropine. Again, if there's a concern, you could always go through medical control for that.
And then how about the hypersalivation with the organophosphates?
Again, it's just going to require super big doses. So,
Will our dose even help? Do we
it may be helpful. It may be helpful. So, these people require like 20, 30 milligrams of atropine sometimes or more.
So with the ketamine even, the dose is 0.5.
Oh, for you said with the organophosphate. With ketamine? This is so rare that I have never done anything with this. I used to pre-treat with a medicine called glycopyrrolate, which just affects the salivation portion of that. But I've stopped doing it because it just confuses people, and it's so uncommon. I just never had to deal with it. If you had to, it's just half a milligram for hypersalivation. So.
But in the presence of an MI, you want us to call before we give it, just to verify that.
I think that would be my recommendation.
Okay.
Because we'll have the EKG hopefully. So we might be able to say like, why don't we hold off, our blood pressure's okay, or no, let's give a fluid bolus, or yes, we should do this.
Okay.
All right. Those are complex decisions that I have a hard time with sometimes too. So calcium chloride, I think we added. We had a hyperkalemia onto here. So remember, if people are having EKG changes with hyperkalemia, and this probably where we're going to see this the most is dialysis people. But with that, with the EKG changes, the calcium helps stabilize the membrane and prevent ventricular arrhythmia. So the calcium is actually really important to give up front. We want to be kind of aggressively giving that in hyperkalemia with EKG changes. So someone who has known hyperkalemia without that, I'm probably not going to do it. But if I get EKG that's very suspicious for hyperkalemia, I'm coming from the dialysis center, that would be a good one for. The same problem we run into post-crush syndrome. We get hyperkalemia from the damage to all the myocytes. Additionally, we get hypocalcemia as well, as our body soaks up all this calcium from the injury too. So there's a couple reasons in crush that calcium chloride is no benefit.
Mike, sometimes we're given this prophylactically at code at the dialysis center. Is that what you think about that?
I think it's probably not going to hurt anything. Calcium does have a pressor effect, and there is actually some thoughts about giving calcium chloride in massive trauma, even in the absence of giving blood, but we're not doing that yet. So.
Are we more likely to run into somebody who's not been coding because they haven't been to dialysis or never knew that they were in renal failure?
Yeah, I think.
And that's, I guess my question is, I've run into this actually, and that's what they need. Calcium chloride seems to turn them around a little bit.
Yeah, I think it's, if they're in, if they've missed dialysis and they're at the dialysis center getting a run and they've missed like 1 or 2 runs, then I would probably do it. If they've been super regular, I don't know, maybe not, but it is a treatable thing we can do, and it's not going to hurt anything. So unless we.
But what if it's just a normal code? Like I had a patient who.
A normal code, where?
He remotely, but he came in. He was in kidney failure, and we ended up having to give him a ton of calcium chloride just because he didn't know he was in kidney failure, and he was braiding down into a bradycardic rhythm that we could not fix with atropine or anything else, and we were kind of turning him around with calcium chloride. And not that we'll have that much time, but maybe we will. You just never know. But is calcium chloride going to hurt if we give it in a code situation?
No, I don't think so. I can't think of.
So was that a code that you're talking about?
Yeah, it was horrible.
So how are you
12-hour
turning it
mega
around?
code.
Like getting ROSC and then losing it? And...
Yeah, so you get ROSC for where you go into a totally rhythm for 2 hours, and he'd start to braid you down again, and you couldn't fix it.
Did he have like a sinusoidal rhythm?
It's really hard to say, Mike, because we were like underwater with this patient.
Remotely.
But he essentially came in, he couldn't get out of bed, was in renal failure, and he coded the first time for they did probably just a round of compressions. He came back because we gave him epi, and they, I think, and eventually determined he had Grash syndrome, which is more common, I think, than we think. There's a doctor who's done a lot of documentation on it, but it's bradycardia, renal failure. I'm trying to remember what Grash stands for. But they said the immediate way to fix it is to give them, leave it fed, because you're opening up, but that just wasn't really in our thought process. But anyway, we were kind of bringing them around to give them a ton of calcium chloride over the period of 12 hours before a flight team came and got him.
Yeah. I don't think you're gonna hurt anything. If you get an EKG and they're in like PEA and they have a really short TP segment, then I probably wouldn't do it. Some things that make me think he has hypercalcemia. Someone with general cardiac arrest, probably not going to hurt anyone with 1 amp of calcium chloride for sure. I pretty much am only using it though in people that I'm really suspicious for hyperkalemia though. So renal failure, crush things, like some people who are on supplements, people have diagnostic or suspicious EKG findings. So, does that make sense?
Mm-hmm.
Okay. Let's see. D10 and 50. We left D10 and 50 in here as options. I do prefer the D10, just easier to do, less overshoot. You can use it in pediatric patients, so I do like that reason. Also, if you give like 100 mils of it and they are persistently hypoglycemic, and we just had one of these the other day, then I can just open it up while I'm figuring out my next thing to do. So then I have like a D10 drip. So, super easy. The dosing is very easy for pediatrics and neonates too. So that's another reason I really like it. That you don't have to do any dilutions. There's none of that syringe to syringe things with like sticky connections and weird stuff. So.
Mike, can I just ask one question on that? And it's only because I had a
Yeah.
call that brought up this concern to me. I had, I'll save you all the details, but it was a hypoglycemic who went from in the 50s altered very quickly, trending down, and we couldn't get an IV. We ended up IOing, and he needed sugar, and you can't force D10 through an IO. I mean, it doesn't, and I really would have liked to at least have the option.
How do you force D50 through the IO?
You could push it, it's an ampule.
Well, you can draw out of the bag.
Okay,
Yeah, so just draw out of the bag. Give it as a, pushes into the IO, so.
okay.
It should work the same way. And actually, it's probably lower risk of complications.
Yeah, okay. I didn't think that,
Yeah.
simple, but I hadn't
Super
thought of
easy.
that. Okay.
Yeah, no, good question, because when it comes in the bag, it must drip,
Yeah, that's the thing, I was thinking about everything else, I didn't even, yeah.
But
And I was
yeah,
like, ah, it won't go.
yeah, no, just draw it
Okay.
out.
That makes sense, thank you.
Jeez, Stacy.
Jesus, I know. It's why I never ask questions, they're always dumb.
Everybody knew that.
So we left diltiazem in here. My preference is in stable neurocomplex tachycardias to really use that expert consultation, to be honest. People who have heart failure and you use diltiazem, I've seen multiple people precipitate significant cardiac problems, sometimes to the point they have to go to the ICU. And I've also seen significant hypotension with diltiazem, especially the 20 milligram bolus. So sometimes I'll start with 10. There's a kind of a lot of reasons that I do like, to use medical control for diltiazem. The urgency really isn't there, whether you do it now or in like 30 minutes. Most of the time it's not going to make a difference. If someone decompensates, you have your other options. So, yeah.
You need to fix the concentration.
It's what is it in?
It's 100 and
Yeah,
100.
there's a couple things on there that.
Do you have that? Oh, okay. The cardiologists at the university would call it the diltiazem death challenge. So, but it was pretty rare that happened, to be honest. Benadryl, I don't think there was any significant changes with Benadryl. Any specific questions that come up with it? I would say that if you're suspicious someone has anaphylaxis, start with epi, because the thing that's going to fix the problem they have is the epinephrine, not the Benadryl. So if they get 100% better with just Benadryl, they probably did not have anaphylaxis. So.
How crucial is it that you get into the dystonic patient?
Man, I use it in dystonia a lot if I'm administering it with something else. So things that are high risk for that, like if I'm giving people Haldol, I'll typically give it with Benadryl. But I'm also relying on the dirty antihistamine effects that are like sedation. So because it's sedating at those big doses, like 50 milligrams of Benadryl is sedating for normal people. So I like to use it in combination for that effect. But it also helps prevent that dystonic reaction. So. Reglan's another medicine I'll often give Benadryl with, but you don't have to worry about that stuff. Dopamine, should we just skip this completely? We'll run through the shot. There are some still indications for dopamine, but my go-to pressor is Levofed for a couple reasons. But Duaneb, I will comment about Duaneb. So ipratropium, the anticholinergic stuff that's in Duaneb, that medication lasts for like 6 hours. So if you're doing repeat nebulizer treatments, you only need to do the first one with Duaneb. After that, just albuterol is fine. You're not going to get any additional benefit because of how long that first dose is lasting. So, and you're probably getting, maybe getting a little bit less albuterol. So. questions about doing that? We can do it in line with CPAP, right? I'm a big fan of that, and people who are in severe respiratory distress, hey, you're pushing it in there. I think it's a good way to think about that, so maybe someday we can do BiPAP, which would be my absolute preference for COPD, though. Any questions about that? Pretty straightforward, exciting. Epinephrine. So we have the 1 to 10,000, so 1 milligram, and then we have the 1 to 1,000. Make sure we're not giving undiluted 1 to 1,000 IV. So there are some indications where we're going to give the 1 to 1,000 intravenously, but we need to dilute that somehow or draw out of our cardiac syringe because we don't want to be doing that. It causes a really bad, has anyone ever seen it happen?
Yes.
It makes people feel like they're going to die because it is like a super physiologic dose that is highly concentrated. I've never seen anything bad happen. I've saw some people start having PSVT from it, but then they went out of it. So, but let's try never to do that. It's really bad form. So, let's see. So there are some stuff in here we should go over. So cardiac arrest dose, 1 milligram, 1 to 10,000. Look for changes coming in the new ACLS with that. I'm curious to see what they do. I kind of wonder if they're going to change it to 3 doses and then no more maybe, or we'll see what happens. Anaphylaxis 0.3 to 0.5 IM. Remember IM over sub-Q because the muscle bed has better circulation than cutaneous circulation, especially if there's anaphylaxis. In severe anaphylaxis, you're not even getting enough circulation to the muscle to really absorb that medication well. So that's when we're transitioning to intravenous epinephrine. And I think we have those instructions here. So 0.2 to 0.4 milligrams, 1 to 10,000 IVIO. I would recommend doing that with medical control. If someone's super dying, you could, call as soon as you do it, but I would really recommend using that with medical control because that's easy to get confused and have a factor of 10 error, which is a bad day. So, yes.
I hate to keep asking questions, Mike.
That's okay.
So we're using glucogen in refractory anaphylaxis.
The glucagon.
Glucagon, yeah. And I'm wondering how you feel about that here.
So I think the benefit to glucagon in anaphylaxis that is refractory is people probably on beta blockers, but the dose you have to give is much more than you would normally give for low blood sugar. I think it's like 4 milligrams? Yeah, it's more than we carry.
3 to 5.
Yeah, so I think it's a really good thought, but I think that we're unlikely to get that far down our stuff by the time we get somewhere, hopefully. Because I would probably go to at least a second dose of the IV epi before I start doing that. So that if that comes
Even
up,
if you know they're on beta blockers, is it something that we need
yeah,
to
if it
call you
comes
about?
up, it would be like online medical control type question, I think. So.
I'm just wondering because I brought peanuts into the room and I'm just worried about. Just kidding.
Does that make sense though?
Yeah.
Yeah. So beta blockers, one area. There have been successful litigation for anaphylaxis in a case where they gave glucagon for someone who had refractory anaphylaxis, but there were maybe not a comedy, but a bunch of errors in that before that happened that makes you wonder if they ever really needed to get that far. And they ended up, part of what happened is that they gave the wrong dose. So, fentanyl, any fentanyl things?
The shivering thing was a new ad for us. The C that we added that. We added that. That's obviously something new, but.
So just remember that if people are too sick to tolerate pain and sedative medicines, we shouldn't be giving them. So people have to demonstrate enough stability to get this stuff. I mean, we may want to give them something for discomfort, but If they're too sick, we may not be able to. We do have ketamine now, and we don't have to give fentanyl first anymore, so that is another option for us for that, just to remember. But I think that's a good thing to think about for lots of different medications. So if the patient has to demonstrate that they're stable enough to get X, Y, or Z treatment first. So intranasal stuff in there. Any question about intranasal fentanyl?
Anything with fentanyl and chest pain? that you-
I don't know where the whole thing with fentanyl and chest pain came. Actually, I prefer it over morphine because it's less likely to make someone hypotensive. We used to do morphine for pulmonary edema and for chest pain, and it was based on some studies from like the 50s and 60s where they thought that it lowered afterload. But really what they were seeing is that that was all data from like peripheral venous capacitance, and it affected its effects on preload as well. But they've all kind of debunked most of that stuff. It's no better than anything else. So there's probably there's certainly no survival benefit to fentanyl or morphine in pulmonary edema or chest pain. But I do think that fentanyl in someone who's sick is good because I'd be less likely to precipitate hypotension and potentially make someone who's already sick worse. So, it's also short, so if it does do something, it's not going to last as long. So, which makes it nice for us for some reasons. Furosemide. When they look at big studies of people in heart failure, about a third of those patients are volume overloaded. Another third are probably at normal volume, and then the last third, the final third, is actually hypovolemic. So my go-tos for patients with flash pulmonary edema, the patients are often like really sweaty. A lot of them have wheezing for some reason because I think there's a lot of them have wheezing, and they are very hypertensive, very sweaty with pulmonary edema. The flash pulmonary edema, they have this big afterload response. They get the fluid on the lungs. Nitrates and CPAP are my go-to for that because we're doing a couple things there. We're decreasing the preload, and we're increasing oxygenation, which expands all those pulmonary arteries as well. Because remember, the pulmonary arteries, when they're exposed to low oxygen levels, kind of squeeze down. So we want those effects. And then diuretic medications are down the line for me. These medicines last like 6 hours. The benefits aren't going to start happening super fast. I do still definitely use it in acute heart failure, but got to be mindful of trying to do some kind of assessment of their volume status before we just give furosemide. And I certainly don't give it up front very often for people who are in respiratory distress, and do those other things first. Patients who are hypotensive and cardiogenic shock are much more difficult to manage. Those are the people that we have very limited things we can do pre-hospital. So those are patients where I might still use dopamine actually if I had nothing else, and I'm probably going to really focus on oxygenation for them. So providing CPAP with if they're able to tolerate it. So remember, think of CPAP like peak. CPAP is really affecting oxygenation. It doesn't really affect your ventilation so much, but it's standing open those alveoli during expiration. So, any big questions on furosemide? So glucagon. So we have. This is why the glucagon is going to be difficult for us to give in anaphylaxis. Is that dose that we carry is really not enough to have the effects that we're looking for. And glucagon so people who are on beta blockers, again, the pathway that they need to go through is to generate cyclic AMP, and that's how glucagon works. And it's just an alternate way to get to that. That is a good treatment for beta blocker overdose or patients who have refractory anaphylaxis, who are, they're blockaded, they get a good effect, but we're not carrying the doses that are really needed, so. Again, if you think about it, I would recommend online medical control if you want to use it in a beta blocker overdose. I don't think it'll hurt anything. It does make a lot of people vomit, so. Any concerns? We put it in big letters, endorsed EMTs and AMTs, we only use glucagon
Do we
for hypoglycemia.
carry enough for a beta blocker overdose?
Negative.
Are we running the same sort of issue there, that we don't have enough? Well,
It's also extremely expensive.
Yeah,
How much is it? It's like
$150.
It's $150 a milligram. So, for something we use almost never.
What would be an average dose for a beta block?
Like 3 to 5, I think.
Yeah.
for us,
3 to
it's
5.
1 to 4
Okay.
Yeah.
on Nauru, it's 1 to 4.
Yeah.
But it really kind of depends on
But you're
what your
probably
patient
not-
looks like. Are we looking at our skinny little ladies or our big dudes?
It doesn't, it isn't, unfortunately, we're probably at the doses we carry, we're not gonna get the effects we're hoping for. So, it does take quite a bit, so. All right. Glucose, oral glucose, patients need to be able to protect their airway, is the big red box there. I've seen a lot of people with like pooled oral glucose in their mouth. You're maybe getting some transmucosal absorption of that, but it's not gonna be very fast, so they need something else, so. I do, in hypoglycemia in general, we put this comment down here that the effects may be delayed. Remember, if people have been hypoglycemic for a while, they're elderly, they get their blood sugar up, they don't wake up quite as fast, because their CPU is kind of resetting, and it takes a lot longer, because it's an outdated model. So we do, be careful doing these assessments. Like, I don't need to give more sugar, their blood sugar, I'm gonna recheck it before I give more sugar. So, because it just may take them longer to wake up. So. Haldol. I still like Haldol. I use it a fair amount. We left the doses 2 to 4 milligrams. 2 milligrams is a low dose for Haldol. That's a good IV dose, but IM dose of 2 milligrams is low. 4 milligrams is a pretty big IV dose, just so you get the range there. Those are both pretty safe doses. There is the risk for QT prolongation. If you sedate anyone or chemically restrain them, I'd recommend getting them on the monitor when it's safe, just so you can monitor them. I have seen one person arrest from long QT. It wasn't Haldol they got though, it was Phenergan. But they also got better with the precordial pump, which was good. Ketamine. We're trying to keep the concentrations the same as much as possible, but the availability is always changing, so be sure you rep check that vial every time. So it'd be a good thing to check every shift so you know exactly what you have there.
We really struggled when we put these together, whether we should even put house supply, because it just changes so much, so.
We are going to stay with the 500 only, though, whether it comes in 5 or 10. We decided to get away from the
200.
Yeah.
Yeah. So the 500 is really nice for us to remember because it makes it easier for us to give IM doses when we get to the agitated delirium section. So pain management, that 0.2 milligrams per kilogram, IV, IM, that is easy thing to do, and we are able to do that now without giving fentanyl first. When should we use ketamine? So I think sometimes you'll have patients who are, have a mangled extremity, or they're entrapped somewhere, or there may be an element of, anxiety that's really contributing to their discomfort, and I think it tends to work better there. I still think it almost always works better in conjunction with opiates than alone. So the patients that are really uncomfortable, entrapped somewhere, something like that, a deformed extremity, is when I'm more likely to use it over opiates alone. That's in my mind how I use it. I think remember, as much as you can do when you give it to them to reassure them, their mental state when they get that medicine actually does impact their experience with it. So in some settings, like, it may be better to give some pain control first if they're super hysterical. Yeah, we have that ability now, so I like ketamine. I wouldn't be afraid of using it. Remember that the margin of safety for ketamine is like 100-fold that of fentanyl. So you give 10 times the dose of fentanyl by accident, and that person's gonna stop breathing. And you better hopefully recognize it, and we can treat it, but you give 10 times the dose of ketamine, all you're gonna do is dissociate them. You give it quickly, they might have a short apneic spell, but that person's probably gonna do fine if you did nothing, so just be aware of that. So.
I've been.
Has anybody ever died of a ketamine overdose?
Any what?
Has anyone ever died of a ketamine overdose?
Maybe lost their airway or something.
I mean, they maintain their airways pretty well. I have had some people have like 10 or 15 seconds of apnea, and people kind of freak out a little bit, but most of the time they do well. Like we had a guy super agitated the other day. He already had like 10 of Haldol and 10 of Haldol, 4 of Ativan, and 50 of Benadryl, and he still pushed over one of the security guards like 10 minutes later and tore off for having an ER. And then when we gave him the 4 per kilogram of intramuscular ketamine, and he had a little bit of snoring, but we just put him on his side, and he did fine. So.
I was wondering if you could give this lecture to the anesthesiologist.
Today.
Because they gave me ketamine, I had ketamine for my ankle surgery, and only because I said, oh, I think I can feel him. The block wasn't working, and he was like, oh, ketamine. And I felt like I was on a bad acid trip. So that whole coaching beforehand is really crucial.
And that's,
And
I
it was,
think it applies to the pain control doses, but it's even more important if you're sedating someone with it. Because, I mean, I think the things I'll do is I'll be like, hey, we're gonna give you some medication that's gonna make you feel really goofy. So I was trying to think about something like, what's your favorite vacation you've had? You know, something like that.
Go there.
just acid.
Like your average So, but I think it is a good point, and I know someone who, a veteran who was injured, and they gave him ketamine without telling him, and he thought he had died for a long time.
It's the
And
most bizarre experience
Yeah.
I've ever had.
And then when he woke up, they were like, give him more ketamine. He's like, oh, ketamine, and then the second time, much better. So.
You have to remember, we did talk about adding Versed in the excitable delirium. He said that we not put that in there. We did talk about it, and I just don't know if we added some Versed when you're using it in the excitable delirium.
I think a good way to do that would be to get that intramuscular shot, then get the patient on the monitor, get your line, and then be able to potentially give them some a little bit of Versed as well down the line. But they're probably not going to get out of that dissociative state while you have them. So, but it may take like 5 to 10 minutes to get completely there too with intramuscular, depending on muscle perfusion. A lot of these people are kind of like agitated and they're tachycardic, so they have like hyperperfusion, so it actually happens really quick compared to someone you just give it to sedate them. Like some kid where you're going to reduce his forearm fracture, it takes forever compared to like some big dude who's all like amped. So, Levofed.
Hey, Mike,
Yo,
what do you prefer on excited delirium? Alperidol or ketamine? That's the first
for
one.
excited delirium specifically, I prefer ketamine. And the reason is that there have been episodes of in-custody death or sudden death related to Haldol. And they don't know exactly why that is, but they think it's related to, those medicines are called neuroleptics, and they have some effects that can create like a bad hyperthermic syndrome, which a lot of these patients are already hyperthermic. I wouldn't, in someone who has, I think they have that excited delirium thing, they're undressing, they're hot, I'm gonna go with the ketamine. So. Cool.
Is ketamine ever a bad choice in chemically sedating someone as far as one or the other? Like if you don't know it's excited delirium?
We prefer not to use it in like a schizophrenic patient who's agitated with just schizophrenia.
Okay.
I do think that it may not be as therapeutic, but I think that is even changing, to be honest. because I know they're using it more in like severe depression with psychotic features now, so.
So if they say they have a history of schizophrenia, maybe just try Haldol instead?
Yeah.
Or what would you?
If I think it's a pure mental health issue,
Mhm.
without mental health plus drugs, you know, the severe agitation with, you know, hyperthermia and those kind of things,
Yeah.
then I'm gonna probably go with something like alcohol.
Okay. Thank you.
Like, online medical control for excited delirium, we said no in this one, or just for the.
So what we did is we removed that for this, because I do have a concern that in that setting, it may delay things somewhat. But if it becomes a problem, like when we review this, we may add it back. So just, because I've heard now that the police are calling specifically for ketamine.
Yeah.
Need an ambulance to cover some ketamine. So, I don't know where that came from, but the last person we gave it to, I think legitimately needed it. And that, I mean, that guy on 10 of Haldol intramuscularly, 4 of Ativan, and 50 of Benadryl, 10 minutes later, knocked over a security guard. And the only reason he didn't knock me over is he fell into the wall. So I was able to, you know, like lock him up and get him back to the room at that point. So thankfully he ran into one of those metal trays. It's on video too, I guess. Levofed. Sorry? No, that's an ER video, because they were watching it and they're like, oh crap, that's gonna
Well,
get
you
laid
should
out.
be loading that video up.
It's for confidentiality reasons. I will say an underhook and pike really breaks someone's posture to the point that they can't resist you even if they're pretty agitated. So, Levofed, there's a big push in those ECC guidelines and post-cardiac arrest care for vasopressors through continuous infusion to prevent loss of circulation post-cross. So we want to, you know, we worked hard to get that. We should be working hard to maintain it. And this is all big change that's coming around. And we've had it started on a couple patients who've come in now. Jim, you had one the other day, right? We had wasn't it you? Or no, Scott. Was it Scott? Scott had one the other day. That's right. So, and I think it was helpful. I actually, sometimes in these PEA patients, I'm running Levofed infusion and not giving them epi intravenously, because I think there's probably benefits to that in certain settings. But it just depends on what you think's going on. But with Levofed, there was talk about like, hey, if we can't get the pump to work, can we just drip this in?
Slip on the edge.
Yeah. If we do that, and I think it's not unreasonable for us to allow that in certain settings, but we need to have a drip chart made up in advance so that you know how many drops per second you need to be doing, so that you're not like, oh wait, a micro drip set has how many drops per milliliter, and then I cancel out the mils per minute. No, we can't be doing that while we're doing that, because by the time you do your calculation, at least if you're me, you're going to be at the hospital. So. We left online medical control for pediatric patients, which I think is reasonable. Most of those kids need fluids. The kids who don't need fluids may need something else besides Levofed, because it could be a heart situation at that point. So those are very complex decisions, I think. So the big warning thing is patients who are severely hypercarbic, like respiratory arrest from COPD. I would worry about Levofed in those patients, because they do, for some reason, the acidosis and hypercarbia is more likely to precipitate ventricular arrhythmias in those patients. So that's the big one that I look for. So. Lidocaine. We left this in here because it seems to come in and out of fashion depending on the year. If there's any big changes there.
How about just the, conscious patient with an IOA as a local?
So what did we decide for that?
1 to 2 cc.
I think it should be less, right? I'm just thinking that's.
There's 20 for CC, so.
So let's just think about that. Do people know what the max dose per kilogram for a lidocaine is? It's 5 milligrams per kilo. So we should be well below that with people. I think it's probably safe. I don't know the data on this. I've seen it recommended, but I can't find where they got this from. So, and it may be helpful. So
You want us to do it?
I think it's okay in someone who's awake. But most of the time, you're putting IOs in people who are not super awake. So I certainly wouldn't delay more important interventions to do it. Does that make sense? If you put the IV in or IO in because you have someone who's like dying and you don't want to sit there and get the lidocaine, lorazepam. I don't have too much on this. I will say that my preferred, we've talked about this before, but my preferred agent for status is midazolam, and there's actually good EMS studies showing that intramuscular diazepam terminates seizures better than intravenous Ativan. Just so you know.
Yes.
But
Just had that argument.
the details of that are a little more murky when you actually look into it, because what's actually happening there is a lot of those times where someone's seizing, it's very hard to get an IV. IM Ativan does not work as fast as IM Versed, and intranasal Ativan does not work. So there's a lot of reasons that Versed is my go-to initially. Now, if I'm giving big doses to someone that I'm going to be completely knocking out later, there may be some advantages to Ativan or even Valium actually, but for most of the stuff we do, I would start there. There's good EMS studies on it. It's shorter acting. It's really safe. So,
Why did we move away from Valium?
why did we move away?
Just because it's
Valium is
longer
very
acting?
long acting. In the elderly, it has a lot of active metabolites. It is slower acting than Versed or Ativan. So I think that there's a bunch of reasons that for EMS stuff with status, I think Versed is definitely my go-to. So.
And we pulled it off years ago, Stacy, because the pediatrics, or the neonatologist wanted it off the truck. Because they said that's the only choice to give to a kid, they didn't want us to give them anything. So that's when we pulled it.
Which is not nice. Yeah, but yeah, I think that Versed is a much more versatile drug for us. So. Ativan's pretty good. So there's some people who still very much prefer Ativan because it used to be like the standard of care, but it wasn't really compared to anything so much. Just so you know, it was compared to Valium actually, IV Valium versus IV Ativan, and IV Ativan was superior. So, but they never compared all three, and then the comparisons when they did IM Versed to IV Ativan, IM Versed did better. So there's no reason to think that IV Versed wouldn't even be faster than that, because because it's so lipid soluble, it's much faster acting than the other ones. So that's why we can use it intranasal when we can't use it with the other ones too. So it's also shorter acting, so if you have too much, you got less time to sweat it. Magnesium, we made some changes here. Asthma and eclampsia, were the ones that we left online medical control for, but we can use it, the indications we left it for. Polymorphic VT, so a lot of times on the monitor, VT looks like it's different, like heights, but what I'm really looking for is that, really sinusoidal appearance to the heights that pushes me to think that, yeah, this is probably, torsade de pointe. And then later, if I'm like, this is refractory VT is one that, again, I might use it. So those are my two things that I'm using it for. So that's the pulseless VT or VFib unresponsive to frontline medications. That's pretty far down the line. Seizures, so I left preeclampsia in here actually. Severe preeclampsia, there's a lot of debate about this, but some of the neonatologists and perinatologists really think that there's probably good benefit to giving this. So severe headache, nausea, vomiting, Abdominal pain, extremely brisk reflexes is also in there, but that can be difficult to assess. So those patients, we may actually prevent seizures in those patients. And then patients, of course, who are seizing in pregnancy, we use it. So life-threatening COPD or asthma. So we put patients with impending respiratory failure or already requiring non-invasive ventilation. Melissa gave this the other day to a patient who didn't have a history of asthma, but had tons of wheezing and was getting non-invasive ventilation. I think it was a very good choice. So someone was like, they don't have a history of asthma, but I was like, yeah, but it actually worked, and they look a lot better, and I think it was a good idea. So, but in general, we're trying to use that for people who have a history of asthma, but I think in that case, it was actually really good use as well. So, I don't think there are any big. Remember, in renal failure, we don't want to be given a ton of mag. It may cause hypotension, so if they're already hypotensive, we're giving it really slow. So, in codes, we're still giving it over 1 to 2 minutes, probably. I'm sure we all do that. There's a diluting in there. So each gram in the vial is 2 mils.
Yes.
So that's 4 mils total in the vial.
No,
Or is it
it's depending on what we get, but right now we
Okay.
have a 5 grams and 10 cc, so it's every 2 cc's you get a gram.
Okay, so make sure, again, you note your concentration, I think, because we have one that's just a 2 gram vial at the hospital, I think.
Yeah, we used to,
so-
that's what we were carrying, but now we have 10 grams.
So, yeah, questions? Again, severe, our primary indications are probably going to be using that for severe asthma, severe COPD. So, steroids, we've talked about this a little bit before. I do think steroids have a benefit in some of these patients. Again, we're going to be looking for the patients who have severe symptoms. So the same things as MAG. They have studied steroids in the hospital, in the emergency room, and pre-hospitally. And in patients who are in severe respiratory distress, it may decrease admission as well as admissions to the ICU. So the effects that we're getting out of the steroids are not happening for 4, probably closer to 6 hours in most patients. So this is something that's working down the line, but we're recognizing that this person is really sick and is going to need this because their course is expected to be more difficult. Patients who do not have severe asthma or COPD requiring, with impending respiratory failure, people who could take a pill by mouth actually have been shown to do probably better taking oral steroids in the emergency room than getting IV solumedrol. And there are a couple theories as to why that happens. Steroids have mineralocorticoid effects that cause us to retain fluid, and they think that some of these patients retain more fluid by getting IV solumedrol at big doses. So a lot of times we're not giving we used to give 125 all the time, and now in the last 10 years I've only done that, for people who have weird neurological things or some other complex reason, because you're really giving that, 60 milligrams is just as good as 80, is just as good as 125, and maybe with lower risk of side effects. There's also, people can get stress ulcers from these really high dose steroids. They may further compromise their immune system. So while they, may need the steroid for the airway effects, you're balancing that with their ability to fight pneumonia or, coronavirus or whatever it is. So,
Mike, what about anaphylaxis?
I think in anaphylaxis, again, if they're critically ill, those are the patients I'm going to be doing it. If they have hypotension and stuff, I think that's a good reason to do it.
Should we put that on here as an accepted indication?
I think that's not a bad idea, to be honest. Because I think that, again, the patients who who are too sick to take a pill are probably the ones who are going to benefit from this. And those are the ones that we're going to be watching for 6 hours anyways. So we're watching them while this medicine is starting to take its effect. So
Think it'll be the same dose?
I'd use the same dose. Yeah. There are rare people where you use these bigger doses, but I'd say the 99% solution is that just give half the vial. So.
Well, if it takes 6 hours to take effect,
So
To not give the 125 when it can be given, the other 62.5 can be given in the ER, right? And not if you feel like they need the 125. So it's not a huge deal that
Yeah.
we're not giving.
Exactly. Because steroids work through receptors in our cells that upregulate mechanisms within the cells. So those transcriptional events, they're called, take hours to occur. So that just, now they do think that there are some effects that occur earlier, but the big effects that we're looking for probably are hours out. So.
We used to carry for spinal or suspected spinal cord injury, is that still not in
That
favor?
data is garbage. So we were still doing it years after the Neurosurgical Society recommended against it. I have no idea why.
Yeah.
So I would always document that it was at the request of neurosurgeon. That's not the right answer. Versed, we kind of talked about all this already. More rapid onset, more lipophilic. I do not use a lot of benzodiazepine medications for pain. And I think that in general, we're going to do better getting good pain control with opiates and ketamine than adding benzos. And we're going to run lower risks of side effects. Remember we talked about how respiratory depression with opiates and that margin of safety? Well, mixing medications that may have not just additive, but multiplicative effects on respiratory depression may be a bad day. So just remember that. So I get that question a lot, and I don't think it, it's a muscle relaxer, but it's not really. And that data on using benzodiazepine-based medications for muscle relaxation is really poor. So while patients may report increased relief, their incidence of side effects and adverse reactions is much dramatically higher. So I mean, that's again why Press Ganey, those surveys are not very good, because people perceive they're not getting something that they need, but in actuality, you're probably providing better. So just remember that. So we may not be, and I always try to emphasize with people that, hey, we may not be able to take all your pain away, but we can help manage it as best we can until we get you to the hospital, to a more controlled setting. So seizures, 1 to 5 milligrams. We put the routes repeat doses with online medical control. I would say that if you give like 2 and 2, you probably don't need medical control, but if you're giving 5 and you want to give more, that's when you need to get into it. Does that make sense? Up to that, that's okay. Pacing and cardioversion. Again, with the extreme agitation, my preference to do that is after I've given the ketamine. So then I can do it more controlled. The intramuscular absorption is kind of variable, and I just always worry that I may get too much effect. So post-intubation care, we have that 5 milligrams IV. Seizures, peds. Any questions on that? I did. Yeah. Morphine, still a really good go-to for pain control. Remember that 1 milligram of hydromorphone, dilaudid, if you guys, I'm sure patients ask for it by name, is about 10 milligrams of morphine. So, and we give 1 milligram, we give up to 2 milligrams at a time, not infrequently for patients with severe pain. So just remember it may take a while to get up there. So people are like, oh, morphine doesn't work for me, but they're only getting like 4 milligrams at a time, and they're spaced out like an hour. So do be aware that if you're stacking doses with morphine, because it lasts longer, you can cause sudden respiratory depression. So as those, you're giving a dose and it's not peaked yet, and then don't have good pain control, you give another dose, it's not peaked yet, you give that third dose, and now all of a sudden you get this cumulative peak, and they're not breathing, so just be aware. And we put that respiratory rate less than 10, oxygen sat less than 90. And we've tried to keep this for objectively painful circumstances. There have been places that have liberalized their use of opiates pre-hospitally, and they've run into all kinds of issues with increased volume of unwanted calls. So just be aware. So the better you get at pain control, the more people will call you. I'm just kidding. But partially that is true, that you have to be careful. Like using this for chronic pain situations can get you into some difficulties, so we've tried to keep it for like the emergent painful conditions. Like phantom limb pain, we had a guy call an ambulance for that one time, so probably not an emergency. because it's already gone.
Mike, this just came up with like a really bad pain. So what's your preference if we feel like we can't move the person?
You know, to be honest, that might be a good case for ketamine. And I've actually been doing that more now for these kind of things, these chronic pain things. One, the abuse potential is there, but it's much less. So, also, they've probably already taken oral opiates, so that risk of sedation. I mean, some of these people that you're talking to, they're asking for their pain still 10 out of 10, but they can't like keep their eyes open when they're talking to you. That's probably not a good idea. Narcan, I don't think there are any big changes here. I would say that we don't see it a lot, but people on these long-acting opiates, remember the overdoses of things like MS-Contin, OxyContin, and what's the other one, like methadone. They can require tremendous doses, so we, think about going to additional doses if you have a really high suspicion for an opiate overdose. So, those patients on those chronic long-acting narcotics. Also, the patients who are abusing some of these fentanyl analogs on the street, some of those things take very large doses. We used to go to 8, but I know that I've read now that some big city places that are having a lot of this go to 10 milligrams. So, most of the time you don't need very much, right? Because if you give that whole 2 milligrams intravenously, it's going to be exciting and annoying.
Can you just talk about the neonate? We talked about that.
We added this?
Yeah.
Yeah, so I think neonatal resuscitation, respiratory depression, again, we left that online medical control for now. You can precipitate withdrawal syndromes that have led to a cardiac arrest in neonates, so just be aware. So start low. Nitro, does anyone know, like in heart attacks, so if you're having a heart attack, how many patients do you need to give aspirin to prevent one death?
Oh,
42. So the number needed to treat for aspirin for a heart attack is 42. So, but we give it to everyone, right? So we don't just give it to every 42nd person, because that number needed to treat is actually very low compared to a lot of other things we do. Just so you know, 42 is a very low number needed to treat, and it's inexpensive. So what's the number needed to treat for heart attacks with nitroglycerin? How many patients do we need to give it to prevent one adverse outcome or save a life? Or whatever?
0.
0.1.
It's infinity, because there is no survival benefit with nitro. Just be aware of that. Don't get too bent shape about making sure we give nitro. I would give nitro in the absence of presumed right-sided ischemic stuff, because I think it is a benefit to get people under pain control without opiates if I can, and it does actually kind of help me risk stratify them. A STEMI patient, you're probably not going to give, or you're probably not going to get pain control with nitro, right? Because that's a complete occlusion, and you're seeing those transmural EKG changes for infarction. But if a chest pain patient who has EKG changes gets better with nitro, his EKG changes, that actually tells me a lot, and that's pretty helpful. So I'm not saying don't give nitro, just be aware that there's not a survival benefit for some of the other things we do. So, we left, we said caution in patients with the borderline blood pressures. What was our absolute cutoff? I don't know what we said. Was it less than 90?
I think you said
Less than
100.
100? Yeah. So, remember that giving one sublingual nitro is the equivalent of starting someone on a nitro drip at 40 micrograms. So that's a pretty high dose. Nurses are usually starting at 10. So you're giving a pretty high dose when you give a sublingual tablets. Every 5 minutes to 3 systolic blood pressure greater than 100, there it is. So chest pain and pulmonary edema. I'm a big fan, again, of nitrates and pulmonary edema, and I think using the sublingual nitrates in that are very beneficial. Those patients who are super hypertensive, they're like sitting bolt upright. Again, I don't know why, but a lot of them have wheezing, it seems like, and a lot of them are thin. They're really the thin patients with pulmonary edema. It can be very beneficial in there, especially with CPAP. So, any questions about nitro?
We did put in there that at some point we were gonna start carrying nitro drips in the field on the ambulance. I think that's in there.
We did put it in here.
Yeah, we did.
So, but for now, we just put it as the range that we're gonna use. I actually think it'd be fine to go to a bigger range too, to be honest. But,
We'll start.
yeah, I mean, because I think we could go to would easily be 40 micrograms per minute, so, but I would start at like 10 usually, and then you rapidly titrate that up. So. Go to talk to one of the cardiac nurses about doing that, because even sometimes the ICU or the ER and some of the ICU nurses don't titrate that up as fast as you probably could. So. Zofran, it's pretty safe medication. They put that black box warning on it just to, like, another company did that against the Zofran company to, that was all like a marketing thing really, rather than a real super big concern. So I know we're using this less in pregnancy now because there is some concern in pregnancy, but it's still pretty safe, just so you know. So someone who is vomiting in pregnancy, they already have alternate things. It's pretty safe to go to this, but it's a little farther down the line than it used to be. So oxygen.
But Mike, do you want us to be giving Zofran prophylactically for anything that's, or is that just an option?
I think it's an option. So if you have someone who says, "Oh man, I get super nauseated every time I get morphine," or fentanyl, then I would give it. I think if you have someone who has a specific condition too, like you have someone who has a penetrating globe injury, and I'm going to be giving them pain medicine, I might give that person Zofran as well, because if they were to vomit from the pain medication, that could be catastrophic for their penetrating globe injury, because then you'll see it all on the outside of the globe instead of partially on the outside. So, because that'll dramatically increase cranial pressure. Patients who have been vomiting with head injuries that again in the group that you're going to be transporting them backwards in an ambulance, maybe it'd be a good idea to give them a little bit of that too. So you're probably not going to hurt anyone with it. Oxygen. We put some stuff in here about maintaining SATs. Really, most patients we want that. We want to keep them greater than 94%. COPD, that range is probably 88 to 92% is a pretty good goal range. So 88 to 94, somewhere in there. There is some evidence that hyperoxia may be damaging, so we want to think about that a little bit. We don't need to have everyone on a non-rebreather anymore. Circumstances where we would use hyperoxia, can anyone think of some? A diving one maybe? We had some diving back there. Air embolism, so suspicion for arterial embolism. Carbon monoxide poisoning is another good one. Those are good. Any questions? Cardiac arrest. There's been a couple providers who suggested that in cardiac arrest we change to high flow nasal cannulas. And I think that's actually a very good suggestion. A lot of places are doing that. The couple advantages with that is when we're doing apneic oxygenation, that mask is not falling off, and it's not in our way when we start managing the airway, so they're probably still getting some oxygenation during the attempt. So that is something I think we're going to be...
The next pit crew, which is next week, training on this, is put a cannula on versus an
Cannula at, well, for now, 15 liters I think is what we're going to use. I'm not sure if ours will tolerate flush rate, but the high flow nasal cannulas will tolerate that 25 liters per minute. So, Pitocin. Who's used Pitocin? Not a ton of people probably, but good to review every once in a while because we don't use it so often. 20 units in 1,000 mils. It comes in 10-unit vials. Anytime you put more than one vial into anything, you should double check because that's like the rule I always had is like, why am I using 2 vials? That should make me nervous. So, anyway, so we're gonna be doing that, and that's for massive hemorrhage postpartum. Let's see, 3% saline, another medication we've talked about some recently. It's in a 500 milliliter bag. We mark those bags somehow, Jeff. They're marked with, is it red tape?
Yeah, it's got a red tape over the top of it.
So, yeah. We're using that for presumed intracranial hypertension. Again, this is probably best used in patients who have what we presume to be an isolated head injury, and they're, have the GCS less than 8 plus one other sign of increased intracranial pressure, like abnormal pupils, posturing, Cushing's reflex, what else do we say, hemiplegia. If they have life-threatening bleeding that's not controlled, their mortality is higher with this, just so people are aware of that. Their outcomes were not any different though when they got it. So while they may have died, the patients who didn't get it in the hospital ended up dying from brain things or being discharged essentially non-functional. So you may be worsening bleeding with that.
So Mike, we had originally had intracranial bleed as a contraindication, and we removed it. Is that what you're saying about that?
Yeah, I don't know where that came from, frankly.
That was very confusing. I was like, isn't
Because
that what we're
yeah, exactly.
supposed to be treating?
What we're hoping to give that to someone who has increased ICP, probably from a space occupying lesion, or maybe if they are already developing swelling from diffuse axonal injury, or one of these shear injuries to the brain.
Then we also add in here, that's not on here, it needs to be on a pump.
I don't know.
We did, because it's in a 500 bag, it would be really easy to let that go.
I thought we were,
I don't remember.
yeah.
You want us to, Mike?
It's a 250 administration, you got a 500 bag sitting there in the heat of the moment.
It's probably not unreasonable. I think if you did it without, I don't remember that discussion, so what do you think? What do you guys think?
I think at a risk.
I think with 250 mils, we're probably going to raise someone's sodium about 3 points. So the chances of them having effects from hyperosmolality, like pontine myelinolysis with 250 mils is very low. A little bit, if they're chronically very low and we do that, we give them all 500 mils, there is some risk with that. But it's still pretty low for a normal person, so I think it's not unreasonable to do it with the pump. So, do that as a safety deal.
Required, you want us to make it required?
We'll discuss that, do you remember?
Well, I know we did, you weren't there, it was me and Kovach and Dave Smith and.
What did Kovac say?
He said, he did say that, he admitted that, so yeah,
I think that's probably reasonable. It's probably the safest way to do it.
Yeah,
The safest.
Yeah, exactly.
Let's see. Other things with 3%. Sodium bicarb. So we put this in here for hyperkalemia and crush injury for online medical control required. That's going to be complex decision making again. In crush injury, we may be giving that bicarb just prior to releasing the crush. So we could give like 1 to 2 amps just prior. We put 1 milliequivalent per kilogram. So I think though, anytime you're doing these crush things at 4 hours, these are pretty complex decisions, and if you can involve medical control, this is a good case to do it, especially because you're stuck there literally. The patient's stuck there, so it'd be good. Hyperkalemia, again, if we see those peaked T waves in the right population, we can give them calcium and then sodium bicarb. The cardiac arrest secondary to excited delirium, again, a lot of those patients can be hyperkalemic as well, and it may benefit them. So prolonged arrests may benefit from this as well. I wouldn't be using this standard in cardiac arrest, but my refractory VFVT patients is one of the populations I may do this in. So.
Are we calling those hypercommunications?
So we put it in there for hyperkalemia, online medical control, and the crush. So, were there other indications that we wanted? I don't know. Tricyclic overdoses. So remember things like tricyclics, really high dose Benadryl overdoses have sodium channel effects. What else does? Dilantin has a really high dose. at high doses can cause sodium channel-like effects. So bicarb in that setting can narrow the QRS back down while you're watching on the monitor and prevent the arrest. So I've watched that happen in a patient that the doctor didn't think took that much medicine, and literally they were like getting ready to intubate them, and you could see their QRS on the monitor just go, and then they arrested. So, and vomited charcoal. It was awesome. It's about everything you could have go wrong at once. So, TXA, we have fairly strict criteria on here right now. Remember, it's hemorrhagic shock. So, you know, there's a trauma patient, they have tons of blood loss. I think actually GI blood loss or massive prepartum or postpartum hemorrhage are other indications, actually, just so you guys know.
They are using that now in the OB, we found out the OB/GYN.
It actually came from the OB/GYN literature. So those patients, massive GI bleeds who are, you know, super sick, really hypotensive, so less than 90. And remember, this 110 number for tachycardia is just a little bit different than just 100. 1 gram over 1 to 2 minutes, and it needs to be done within the first 3 hours. So that's pretty critical because this medicine affects fibrinolysis, which is our body breaking down blood clots, and that excessive fibrinolysis and trauma is kind of for sure done by 3 hours.
So not online medical control in the first hour,
No,
from hour 2 to hour 3.
yeah, so it's getting prolonged. I don't remember that. So it's important to get that time for when they start bleeding too, if you can, so because that dramatically affects it. Some big centers are using really fancy coagulation tests called Rotem or TAG to evaluate patients to determine if they give this at all. And that's probably the best way to do it, but that's not a capability anywhere in Montana has. There are only a couple places in Washington that are doing it, like Harvard U and stuff. So. Trying to think if there's anything else. It works for nosebleeds, but it's not in our protocol.
Are we gonna need Kim? Can we add that?
No.
That was brought up actually.
Yeah.
No, okay.
It needs to be, I think typically for it to work best, it needs to be soaked on a pledget and put in the nose, so not something we can do very easily. An atomizer would probably work if you guys really wanted to know, so if you had someone who was like exsanguinating, you could, you know, aphrenize them or blow the clots out of their nose, spray the afrin in there, and then try and do this stuff. That would be something you could think about, I guess, with online medical control, using a nasal atomizer. We do put that in there. It'd be cool to do. I think that's the big stuff. Any big questions come up with medications? So, I did have a couple things I'm going to put on here for you, Dave. It's I did a traumatic arrest talk for a city fire and a chest pain talk, and it kind of incorporates our protocol elements we have right now, so I'll put those on here. Any other questions coming up that people are thinking of?
So
Mike?
we'll, oh,
Go ahead. What do you think about saran wrap and burns for thermal burns?
So, until the burn is really clean, it may trap stuff in there, is the problem. I think there are some benefits, actually.
How is it any different than a sheet, except better because it doesn't stick?
Well, the sheet is not 100% like conclusive.
Well, the saran wrap's removable also.
Yeah, it's gonna be, but it's gonna trap stuff underneath it more. Whereas the sheet we're gonna take off as soon as they get there. We'll do it with that too. I also do think that there may be issues with using like a over-the-counter product on burn patients. While it's known to be sterile because of how they make it, it's probably not offering us a ton of benefit over just doing the burn sheet. Now, really prolonged, unusual things, evisceration stuff, there may be some benefit to that. So, but for now, I think it's kind of outside of our standard care. So, it is an option if you had nothing else. So.
Okay.
Mike, do you want to give us any preview on what's coming up with airway stuff for us?
I think it's the same stuff we've emphasized that we kind of all have come to understand now is that in cardiac arrest, our time is probably better spent doing chest compressions than trying to intubate the patient. And so using supraglottic airways is probably preferable. Now, there are patients who are getting continuous CPR with the Lucas device may do better with an endotracheal tube when they broke this down from some big studies. But in general, I think that we should be probably just rapidly putting a supraglottic device in these patients because we can do it about a minute faster than endotracheal intubation with a higher first pass success, probably in the 80 to 90% first pass success versus somewhere between 50 to 70% first pass success with an endotracheal tube. So,
That including respiratory arrest?
So like a respiratory arrest who is now in cardiac arrest or?
Yeah.
Yeah, I think, I would just, honestly, I think it's the preferred way to go. And I think that that'll be a change sometime soon, so.
We're gonna train on a bunch of airway stuff in next month.
The patients now, if you try and put that in and you can't use it because of some problem, like they have an anatomic problem, you can't oxygenate or ventilate with them, we still have to be able to, we're not gonna take away endotracheal intubation, but we do need to, so we still need to be really good at that by continuing to practice it and stuff. Where did that? Okay. Is that the wrong computer?
No, that's right. Just hit that folder.
This one?
Yep.
Oh, there we go. I'm not going to do these whole talks today, but they're, I think the other one's ACS actually. There it is. So they're on here for people to look at. So.
We'll put them on a lab table.